similarly guaranteed health care for all residents of New York State. And I'll sort of talk about the similarities and the differences and how, you know, one really feeds into the other, and how they complement each other. And just by way of background, I actually have a master's in public health from the London School of Hygiene and Tropical Medicine, where I studied health policy planning and financing. And now I get to teach health and human rights. And I actually teach a class called health activism at Brooklyn College, which is sort of an amazing thing to recognize, that the, you know, social justice aspect of public health and the importance of social movements and, you know, the gains that were made in public health through, you know, this kind of direct action and generally, you know, being active in the field of public health. So with that, I do have some slides. I don't love when I do my own teaching, I don't love to share slides, but I think for, you know, some sort of dramatic imagery, there are some graphs that are, you know, I think, you know, important to show. But I'd much rather talk about, you know, kind of the principles of you know, what is behind the slogan of Medicare for All. So, you know, Medicare for All, really the full kind of slogan is expanded and improved Medicare for All. As we know, if you yourself are on Medicare, or if you have neighbors and family members and friends who are on it, you know that it's not yet a perfect perfect system that needs some work. But basically, the idea is that you know, you'd have guaranteed care that treats care as a human right, that treats healthcare as a public good, that is not tied to things like your job. It's not treated as a commodity. I think, you know, just in the last, you know, 4 to 6 years, for a whole host of reasons, it's really become kind of front and center, you know, in a way that a movement has really coalesced behind this healthcare reform. You know, maybe at some point, if folks are interested, we can actually have a discussion around how that ties into kind of your strike demands too, if, you know, what it would mean for you all to have guaranteed healthcare without it being connected to your jobs. And, you know, with also the understanding that it's only some jobs through which one receives health insurance, right? Not all jobs do. For instance, I have 3 jobs and none of them offer me health insurance. So I have health insurance through my husband's plan. All kinds of ways in which, you know, having a principle of guaranteed health care would really kind of, you know, be a liberating thing. So I will, I can share my screen, right, Lisa? Let's see, I'm trying, yeah, I think it's this one. Just to kind of set the stage a tiny little bit with kind of this image. Let's see. There we go. So this is a recent sort of a visual representation that somebody on the Board of Physicians for National Health Program has put together, which is, you know, really how, you know, messy our health system is. And I would actually go further and first of all say that we don't have a health system, but rather health systems. So it's fragmented, and also, you know, aside from being a mess, if you know, kind of walk away with one thing after today's teaching, I would say that, you know, this setup is not, you know, people talk about a healthcare system being broken. And what I'd like to emphasize really is that our system is not broken. Our system is like this by design. So this is not you know, it's not an accident. We didn't sort of, you know, end up like this accidentally. It's been very intentionally designed to be, you know, essentially confusing, but really more than that, which is it's, you know, profit seeking. It puts profits over patients. And there are all kinds of, you know, systems, like I said, that don't talk to each other, that generate a lot of waste. So let's see, let me move this forward. I find it very useful to look at health systems across the globe. And in fact, I was involved in a project with the Commonwealth Fund looking at healthcare systems in 20 countries, from, you know, China and Taiwan to Brazil and a number of European systems. And what you find, and even though these numbers are outdated, you can see that from 7 or 8 years ago, the US tends to spend twice the amount of money on healthcare to any other industrialized country, right? So close to actually 18% of our GDP is the totality of how much we spend, and just compare that to what other countries do. And the reason I mention this is, it's worth looking at examining, whether the U.S. Uses more healthcare than in other countries, and also how we fare with regard to, health outcomes. So this is just, I'm going to show you really quickly a few of these graphs, but just to see what hospital inpatient days look like for, the U.S. and then, compared to a couple of other industrialized countries. Like I said, that spend a lot more on healthcare, that have, systems of universal care. Here's the number of physicians per capita. The U.S., compared to all of these other countries, actually fares worse with fewer physicians. You would think that maybe we have a higher percentage of the elderly, which is why it's, so expensive. But if you look at, again, compared to a number of these of other industrialized countries, you see that is actually not the case. We have a relatively younger population. You'd think maybe we're sicker, right? Maybe we smoke more. And so that's why our outcomes are so poor. That's why we spend more money. But again, compared to other countries, you'll see that is, again, not the case. And so again, going back to my, the fact that we spend 18% of our healthcare, you'd think that maybe our health outcomes are, sort of better. But unfortunately, we routinely place last in all indicators that show how well our system is performing. So for instance, in terms of health expectancy, you'll see where the U.S. Falls on this graph compared to other industrialized countries. And again, this data is a little bit, a few years old, and you may have heard or seen reports the last couple of years that life expectancy in the U.S. has actually gone down in the last few years. This is just very specifically tied to uninsurance and the preventable deaths. If we had guaranteed health care, these are, just egregious numbers. Maternal mortality, another indicator of how well your system performs. And in the U.S., we do incredibly poorly. And in fact, again, the maternal mortality in the U.S. in the last 10 years or so has actually gone up, where it's been reduced in many other countries. And of course, if you look at this number more closely, this is in the aggregate, but were you to, parse this out and look at it in different regions in the United States and among different demographics, you would actually see that what this masks is an even greater disparity, especially, you may have seen recent reports of maternal mortality, especially in the Black community. And in the state of New York, if you're Black, you're 10 or 12 times more likely to die in childbirth than if you were white. Like I was saying earlier, Jeff, that there's just been an increase, and compare that to other countries where in the last 10 years they've actually made gains and decreased maternal mortality. I think it won't be a shock for you to hear that there are also persistent racial health disparities. And this is a map of New York, where you'll see with regard to just asthma specifically, how, children, if they're in East Harlem or in the Bronx, fare compared to, say, folks who are down in, Tribeca or Chelsea. And so the question really is, right, my premise was we spend so much money, it must be that we use a lot of healthcare. Well, that's not the case. Well, okay, then our health outcomes must be better, but of course that's not the case. So we spend almost 18% of our GDP, and where's the money actually going? And this is where it gets really, really interesting and also infuriating, which is, check out these guys. Again, this is data from a few years ago, but it's not going to be a shock to you to see that CEOs of big insurance companies make bank, shareholders as well. And I will also add, and we can talk about this a little bit more, because we should, of course, address what happened and what's been going on in the pandemic. They've made bank during the pandemic, private health insurance. So this is one place where our money goes. So you'll see in terms of overhead where we stand compared to other industrialized countries. the growth, oh, what happened to this? Oh, here we go, excellent. So you'll see also that since the 1970s, this graph will show the growth of number of physicians in the United States compared to administration. So the bloated administration that is necessary to maintain that fragmented system that I was showing you at the beginning of the slide deck. Drug company profits, right? I mean, this is an important conversation to have around the vaccine development and the vaccine rollout now. But here's how much they've gained, in just the last 20 years or so. And one of the things that has also hit the headlines is the cost of life-saving insulin, with people either taking trips to Canada to purchase cheaper insulin, rationing insulin, and of course, tragically losing their lives to insufficient, access to it. And so, of course, we do have a solution. The solution's been around for a long time. It's gained traction, like I was saying at the beginning. Remember that messy graph I showed you at the beginning? Well, here's one that's, straightforward, which is that businesses and people together pay a tax. Through the government, it gets, accumulated into a public health insurance plan, and that insurance plan is what's used then to reimburse doctors for their services. And just really briefly, how it works, the principles of a single payer system. Like I was saying, businesses and residents pay an affordable premium to the government. It funds the insurance plan. And reimburses doctors and hospitals, and then everyone is covered regardless of, whether you have a job, your immigration status, your health status, and many other kind of conditions upon which our health insurance currently is contingent. So just to share with you a few core values of single payer. So first of all, it covers everyone. And at the national level, when we talk about Medicare for all, it obviously means all residents of the US, regardless of, like I said, immigration status. In New York, that means residents of New York State, if we're talking about the New York Health Act. It covers all medically necessary services. And basically the way it's been developed in New York State is that it covers everything that currently Medicare and Medicaid cover. And the newer iteration, the New York Health Act, which is in some ways more progressive than the Medicare for all at the national level, also covers long-term care. As our population ages, and also recognizing that there are folks with chronic needs, people with disabilities also who have, what is considered expensive care. And it also includes, domestic, health aides and other domestic workers in the plan in terms of, access to care. With no narrow networks, you have free choice of doctors, dentists, nurses, hospitals, and so forth. So basically what we have right now is, you have a health insurance plan that takes you, to a website where you choose a doctor based on, whether they're a network or not. And this question of choice, I think we should unpack a tiny little bit maybe after I'm done with this presentation, but it's essentially Medicare for all that gives you a choice. And the choice is based on, your provider. Not on choice of health insurance, which, as we well know, we don't actually have a choice. So there are no financial barriers. So there are no copays, there are no deductibles, there are no co-payments, no co-insurance as well. All the things that are put in place to basically put up a barrier and prevent you from accessing the care that you need. Really important in terms of how we finance it. And again, this may come up, how do we pay for universal health care? Well, it's paid through a progressive tax. And of course, it's an equitable quality care delivery system that serves everyone. Louisa, I think there's something going on with my internet, but can you still hear me?
Yeah, we can still hear you.
Okay, sorry about that. I may want to, I'm going to end my formal presentation anyway, and maybe even just move over to the place where my internet signal may be a little bit longer. But why don't I, before I talk about a few more sort of things that are important from, from a perspective of, the principles of having universal care. Is there anyone who has any questions about anything that I've just that I've just covered. And if you can just, because my video went out, if you can just tell me, maybe either read it out if it's in the chat or
yeah, I can.
You want to unmute folks?
If people want to unmute with questions, that's great. I can also read things out in the chat.
I was mainly focusing on calling representatives and constituents. I did put it in the chat already, but if those came in early or late, I don't know. But to talk to local Congress and Senate policymakers regarding education reform, healthcare rights, what have you, and what we're seeking, you can call 202-225-3121 and demand put pressure on policymakers in the Capitol. And I tried calling the White House, but their current phone bank is down, ironically. So there's one person that is the point person that will connect you based on your zip code, who to call, and what have you. So just point of information.
Thank you so much for bringing that into the conversation. That's definitely part of, the question around how you can get involved and what you can do. I mean, at this point, right, this is a question of, so there are bills that have been in existence for over 30 years, both at the national level, right, in Congress, but also here at the state level. And they finally are gaining some really important traction to the point where I will tell you that it's historic that the New York Health Act here in New York State has 32 pledged supporters in the Assembly and 33 state senators. And this is the first time this is, this has ever happened. We've always teetered between 30 and 31, so just short of a majority. So we're in a place now where, at least theoretically, were there to be a vote on the New York Health Act on the state level, there's a good chance that it would pass. And basically, then what that means is then it would go to the governor's desk for signing. Now, I know the governor is not traditionally been a fan of a state single payer systems. He has told us openly in meetings that he much prefers that Medicare for All be, a national program, and we couldn't agree more. Except, we suggest that, he can start by signing a single payer bill at the state level, after which, we would see hopefully a domino effect where other states would, sign similar bills, and then it could sort of progressively, cover the rest of the country. And the reason we say this is there's, there's precedent to this. So for instance, in Canada instituted a single payer system in the state of Saskatchewan, and then slowly it spread to the rest of the country. In fact, I'm forgetting what exactly his title is, but I think the governor, the head, some high-ranking official at Saskatchewan who instituted single payer at the time is actually, to this day, remains the most popular Canadian president. And I don't think, Canada in so many ways is so similar politically, historically, to the United States, and even more conservative, kind of voters in Canada are deeply defensive of their Medicare for All system. So a lot of times, when I talk to, constituents, when I talk to people on the street, I say that what we want is similar to what Canada already has. So just in terms of, to piggyback off of that, if you can check out whether your representatives have signed on to the bills, we encourage folks to thank your assembly folks and your senators if they have. You can do so publicly on Twitter. That's always really nice. And if they haven't, just, it's really good for them to hear from us and say, here's all the reasons this is why this is super important. And I will just say, from the perspective of workers, it is decoupling, health insurance from your job and not having your boss control it. Is sort of the ultimate, liberating, kind of argument for having, guaranteed health care. And one of the things that, where, as I said, my daytime is at NYSNA, which is the New York State Nurses Association, at one of the facilities when they went on strike in December. The number one fear was, continuation of care, and the fear that the employer was going to cut their insurance for the duration of the strike. And for those who, there was for folks who had serious health issues, that was a really big consideration and a huge fear. And you see the same thing happen with GM, right? The first thing when they went on strike, I believe it was around 2 years ago or something, the first thing they did is that the bosses took away their health insurance. So while a lot of resistance is around this, idea that, first of all, just change is scary, and people talk about it, and this with the framing of, what they're going to lose, what's being taken away, and especially in the labor movement sort of setting where it's a really big important kind of bargaining chip, right? The health insurance always is front and central in negotiations. From our perspective, if you were to take it off the bargaining table altogether, then you would be able to bargain for other things, including wages, parental leave, and other other improved working conditions. So there's, to me, it's just an incredibly strong argument for why workers should want such a thing. I'll also mention another, sort of very practical reason for why you would want something like Medicare for All, which is from an actuarial perspective, you want to have a really diversified risk pool. And so at the moment, I should also just say, when that first image that I flashed with how messy and fragmented our system is, I feel to sort of describe that a little bit, so I'll take the opportunity to do some of that now. So you have programs already, such as Medicare and Medicaid, that are publicly funded through our taxes, right? You have CHIP, you have the American Indian Health Insurance System. Then you have the VA, and the VA is socialized medicine. So the thing that they have in the UK, the National Health Insurance, it's government actually run. So all of the VA hospitals are actually government hospitals. The employees who work in the VA are government employees, and it is, which is not at all what we're proposing when we talk about Medicare for All. So, and then of course you have the whole private health insurance industry. So you have sort of completely three different systems that coexist, but really don't coordinate, and are not good at talking to each other. And so basically what we'd like to do is to unify these systems, unify the pool, because at the moment, our poorest, our sickest, and our oldest populations are covered by public funds, right? Whether it's Medicare or Medicaid, and in any system, those are the greatest users. And so those of us who are younger, who are healthier, and who are working, our funds are being funneled away from what would be kind of this common pool that would serve to all of us, essentially. If not at the moment, then at some future moment, because we're only able-bodied until we're not, right? Instead of having this division between our insurance funds, like I showed you just a few minutes ago, going to line the pockets of executives and of shareholders of these, big systems. So there are just, there's just so many arguments to be made from a number of sort of perspectives, and what's keeping us from achieving it. I mean, you can very well imagine that the moneyed interests have incredibly deep pockets when it comes to kind of lobby groups, whether it's in Washington D.C. or in this case in Albany. The power of the health insurance industry, the power of the pharmaceutical industry, and the fear mongering that's been going on for, at least the last 40 years, but probably longer than that in terms of, the government takeover and taking away the question of choice. And, I just heard, and this is something that's repeated often, first of all, the idea that you have choice if there are a number of health insurance plans out there, which is obviously not true at all, because we know that we get our health, if we get it through our employer, it's whatever our employer can offer. And two, if you are choosing between plans, obviously you're going to choose, especially if you're going to choose the one that's, kind of your financially, is available to you. But you can't really plan for, accidents or an onset of an illness. And so it's just, really unrealistic to think that you can choose your health insurance the way you would any other, sort of commodity on the marketplace. So this idea of choice, I think, is just a false one. I saw a clip recently of John McCain, the late John McCain, when he was running for president during his campaign, talking about one size fits all. And I just find that is not an apt metaphor. It's not like we're handing out, shoe size number 6 to everyone, and it's either too large or too small for folks. I would excuse the kind of metaphor, but I would argue that it's more like a buffet to which everyone has access and takes or uses in terms of services what they actually need, with everything being available under a single umbrella. So those are, like I said, those are just some of the principles on which a program like Medicare, improved and expanded Medicare for all, would rest. Like I said, the New York Health Act will do something very similar in New York. And it seems to be regaining, there's huge gains, and we're very close to New York. And we're hoping that if something like this were to pass, this law would pass here, that could be a real kind of boon to other states. I think there are something like 19 or 20 other states that also have similar bills in their local, in their state legislatures. So again, I'm really sorry. I'm trying to reconnect to the internet. So Luisa, if there are any other questions in the chat, or if anyone else has their hand raised, unfortunately I can't see it, but you should feel free to interrupt me and ask.
Yeah, thank you. I actually had kind of a point I wanted to raise, just coming into the specifics a little bit on like how Medicare for All and the New York Health Care Act, I think, are really deeply connected to our fight. I mean, what you said before about like the economics and bargaining being easier if you're not bargaining with your... Oh. I think there's a little feedback on your phone, Anna.
Sorry, I'm just trying to reconnect. I apologize.
Okay. Yeah, I think it's okay now. But I was just saying about the economics being easier to bargain if one of the things that if you take off asking your employer to pay for premiums on healthcare. But also, I think something that we don't necessarily talk about as much is that like graduate workers generally have a cap of being paid for 20 hours, even though most grad workers I know work much more than that. But there's a lot of like state benefits related to healthcare, and I mean unemployment too, but and childcare as well, that you have to work more than 20 hours a week in order to qualify for. And I think that's also like a big barrier, one with graduate workers who are in that position, but also, like you said before, with people who are working multiple jobs and not like don't have a paycheck for that's indicates they're working more than 20 hours a week. But I did also want to ask, I think like obviously there's massive problems with big pharma and insurance companies. But I also know there are a lot of employees in those companies who aren't like, the big CEOs who are making way more money than they need. And I'm curious if in the transition to like Medicare for all or New York Health Act, like kind of if there's any like new jobs plans for people who are currently in those positions and like actually do really need that money.
Thank you for bringing that up. It's super important. I mean, we're super committed to a just transition. And so essentially what that means, and I am a little bit more familiar with what this looks like for the New York Health Act specifically. So the job loss is estimated to be at around 200,000 in New York State. Because what we're looking to do is to do away with the private health insurance industry altogether. So there are a couple of things to note. First, these jobs are already being outsourced, and a number of companies have already started employing folks in, say, English-speaking Caribbean, for instance, of course, India and the Philippines and so forth. So this is, in some ways, unfortunately, this is already happening. I mean, there's the larger picture of contextualizing this in the global context is also incredibly important. And we, definitely have to take a look at that, especially with, the global pandemic and the vaccine distribution and, where the vaccines were developed versus who has access, who's hoarding it and who gets priority and so forth. I mean, these are global issues, right? So that said, there is absolutely baked into the New York Health Act a 2-year transition for any worker who in the insurance industry who will have lost their employment with re-education and the ability to re-enter the workforce in a different capacity. One thing that we are going to see is an increase in demand because right now there are so many barriers to healthcare. The idea is that once those are lifted, right, the demand for care is going to increase, and so there are going to be a large number of jobs that are needed, and by some economic estimates, the number of jobs that are necessary to get us up to where we actually need to be, because there's a deficit of healthcare workers, whether it's physicians or nurses or health aides and so forth, actually kind of balances with the number that would be lost in the health insurance industry. It's just I just want to be really clear that we are absolutely 100% committed to a just transition, yeah. Just what you mentioned, the pharma industry, essentially what we'd look at is regulating the pharma industry. A funny sort of interesting story, when Pete Buttigieg was running during his campaign, he was bird-dogged by a Medicare for all person, and they said, well, would you support Medicare for all and a single payer? And Pete Buttigieg said, well, look at Germany. Germany doesn't have a single payer system, and they have universal health care, which is true and really disingenuous on his part, because even though Germany is a multi-payer system, which is what the U.S. is as well, they have a highly regulated pharmaceutical industry, and their health insurance industry, even though there's something like 440 plans, are completely nonprofit. So it's not at all apples to apples. And the one thing that I do, like I said, I really appreciate comparing health systems across the globe, because it's really, really helpful to know that what we have here is it doesn't have to be like that, and it could be different. And there are models out there which we can look to. There aren't two models that are the same. Every system has come out of their own sort of very specific historic and political context. And so the NHS, which is essentially socialized medicine, came out of, the ashes of World War II, I think in a way that the capitalist system that, the UK is probably would not be allowed to, exist and flourish today. In fact, it's constantly under attack, right? So, the circumstances out of which these systems are created are also really important to note. And so there's this idea of, what the U.S. wants is what every other country has, and that's actually false, because every country has a completely separate system, some of which are multi-payer. In the U.S., the movement for universal care has coalesced around the idea of a single-payer system for, I think, a whole host of reasons. One is Medicare already exists as a system, so what we're asking is that we expand it. Right now, it's a universal system, which when you turn 65, you automatically qualify for, and what we're saying is we wanted to expand so that it includes everyone in it. So in some ways, the idea and the principles already exist. Two are, like I said earlier, our neighbors to the north already have something like that in place. And three, Taiwan, which underwent a really serious healthcare reform, very similar, and their system was similar to what we have now, and they have a single payer system in place right now, is also a very recent model of serious, deep health reform, healthcare reform that happened and that's possible and that we'd in some ways like to emulate. I mean, the biggest argument is the system that we have in place right now is not sustainable. The costs are out of control. We have a segregated system that, treats patients differently depending on what kind of health insurance they have. And I know that we don't have a ton of time left, unfortunately. Time just seems to have really gone quickly. Before I leave, I really would like to show you a very brief video. And to me, some of the most important principles around organizing for a single payer system, which both tells you the origins of kind of this fragmented system, the birth of Medicare and Medicaid that comes out of the civil rights movement in the 60s, and also why having a single payer system is a feminist issue and a racial justice issue. And so there's I'm just gonna, once again, I'm sitting next to my router, so I think things should work well right now. And thank you so much for your patience. I'm really sorry. This has been a little bit of a, do you mind allowing me to share my screen? It looks like it's been disabled. Maybe just make me co-host again.
No problem. You should be all set now.
Yep. Risa, what if I shared the link with you and maybe you can try it on your end? Okay, let's see.
Sure.
Okay. There we go.
All right.
Have never heard before. Among high-income countries, universal health care is standard, except here in the United States. Why is that? Here's a reason that you may have never heard before. Our failure to pass a national health plan is largely due to America's history of structural racism. In 1945, Democrats were in control of the House, Senate, and the executive, and President Harry Truman decided to push for national health care. That year, 64% of Americans supported a national health insurance plan. Support in the states' right South, which was heavily Democratic at the time, was even higher than the national average. Seem too good to be true? That's because Truman's proposal would have expanded health coverage through Social Security, which at the time explicitly excluded agricultural and domestic workers. That meant 60% of Black men and 80% of Black women were not eligible for the benefit. However, the push for national health care coincided at a time when challenges to Jim Crow and discriminatory provisions in federal programs like Social Security were also underway. In 1946, Truman established a Civil Rights Committee, which desegregated the military and banned discriminatory hiring practices in the federal government. Southern elites began to link new proposals coming out of Washington with threats to segregation in education, healthcare, and housing. The possibility that a national health plan would desegregate the healthcare system and institute a significant transfer of wealth from whites to Blacks caused Southern support to plummet from 66% in 1945 to only 22% 4 years later. Southern elites were a core constituent of the Democratic Party at the time, and nothing could be passed without them. In 1949, around the time every other wealthy country was moving towards universal health care, the Democratic coalition fractured and Truman's plan in Congress died. In 1964, the NAACP won a landmark Supreme Court case requiring hospitals built with federal funds, which was most of them, to desegregate. A few months later, the Civil Rights Act was passed, reinforcing this mandate. Passage of a true national health plan was still blocked by Southern Democrats in the 60s, since after the Civil Rights Act, this would have meant desegregating the entire healthcare system. So in 1965, the Southern delegation finally came to the table to negotiate the creation of two groundbreaking yet limited healthcare programs: Medicare, which initially covered only seniors, and Medicaid, a state-run program for certain groups of low-income people. The Dixiecrats ensured that these programs were designed as much as possible around the racial hierarchies in the healthcare system. For example, Medicare is split into two parts. Part A, the part that covers hospital care, requires no premium. Medicare Part B, the part that covers physician care outside of a hospital, does require a premium. Why split Medicare into two parts? Part B was designed this way so that physicians' offices in the South could claim that it was a voluntary insurance program, not a direct government payment, and continued to racially segregate their offices and refuse Black patients. And why was Medicaid created as a federally funded but state-administered plan, while Medicare was administered by the federal government? This compromise allowed Southern states to discriminate against low-income people of color in terms of eligibility as well as benefit levels. And this also dramatically slowed the desegregation of nursing homes. While Jim Crow laws no longer exist, the impact of structural racism on our country's healthcare system has been profound. People of color are still overrepresented in states that have poor safety nets and strict Medicaid eligibility requirements, and new waves of immigrants, particularly Latinx, have fallen into these systems of racial inequity created for African Americans.
That'll do. There was a little glitch there at the end. It didn't play to the end, but the message was basically transmitted. So just, a reminder that when you have this kind of fragmented system, first of all, to connect it to just labor and valorization of work, if you look at the agricultural workers and domestic workers who are being excluded, and how we define value care, value work, and then of course the added kind of complication of connecting it to jobs, and like I said earlier on, certain kinds of jobs or certain kinds of provisions before these kinds of things kick in and so forth are just all like really discriminatory. Profit maximizing seeking should not be how healthcare is administered. Right, it should be, like I said, a public good. It should be healthcare is a human right, we're, like I said, gaining, both of these programs at the state level and national level are gaining a lot of popularity. And so, just if there are any questions around what you all can do, I mean, first of all, just talk to your friends and neighbors and family members around this. Two, if you belong to organizations, if you or associations or clubs, invite us. It doesn't have to be me. We have a big kind of speaker bureau of folks who are willing to talk about these things. And there's PowerPoints and presentations and more interactive kind of chats that we can have around this, especially around how you answer tough questions like, how do you pay for this? Or like, what about those smokers? Why am I responsible for somebody who, such and such, fill in the blank for, why do I have to pay for them? Or, any number of things that sort of really, or, healthcare is something that you deserve, or, that you worked hard for, as opposed to, your neighbor who's, again, fill in the blank. So there are all kinds of ways in which people kind of push back, and, we have some useful talking points to that, for that. If you're a healthcare provider, we have petitions for you all to sign if you'd like to write an op-ed or join, a team that can help, share the message through media, of course, social media, especially now at a time when we're, coming out of, but have been sheltering in place. Twitter has been a real great way to reach legislators because they have been paying attention. And like I said earlier, just call your electeds, ask them if they support it, encourage them to support it. The more they hear from us, the more kind of top of mind it's going to be. At the national level, I'll say that. Representative Pramila Jayapal, that represents parts of Seattle, has just reintroduced the bill there, and there are 114 supporters there as well. So we're moving along, but there's just a ton more work to do, both in terms of sharing, spreading the message, building coalitions around this, and then of course pushing our electeds to not just embrace it but also run on the support. I think maybe you saw the headlines after the election in November that representatives that ran on Medicare for all had re-won their seats. So it's a really powerful platform on which to run. And I'll stop there. I realize it's 7 to 1. I'll take maybe 1 or 2 more questions, and then I'll let you get along with other business that I'm sure you have to take care of. Well, I'll just say in closing then that the 2 major organizations, one local, the Campaign for New York Health, that's the shirt I'm wearing here. Check out our website if you want to sign up for more information, hear what's going on, nycampaign.org, and Physicians for National Health Program, which is the other organization through which Lisa reached us, also does a lot of work, both locally, but also, nationally as well. So, you want to maybe keep in touch that way. We at Physicians National Health Program, we do a monthly educational forum that's free and open to the public, and we talk about different aspects of why single payer would be good for, and then fill in the blank. So in April, we're talking about why it's good for hospitals. And if you know anything about kind of our, again, super dysfunctional hospital system with, private and public, and in New York especially, the H&H system is overburdened and it picks up the slack for the private hospitals. I'll tell you how perverted it gets. Private hospitals actually hire ambulances to pick up patients off the street, those who are considered expensive patients with multiple comorbidities, and drop them off at the doors of H&H so that H&H would treat them because it's too expensive for them to do so. So, I mean, this is not just, like I was saying earlier, an accident. This is a very deliberate attempt at, really segregating a system and making sure that the private, or in our case, they're actually considered nonprofit, continue to maximize their profits and get only, patients who, they would reap as much profit from. Anyway, long story short, just, healthcare is a human right, and let's get this passed. Thank you so much for having me. I really appreciate it. If there are any questions at all, maybe let Lisa know and she'll know how to get in touch with me and with our organizations. Best of luck. Stay strong. Sending so much solidarity and strength to you all. And sending and love and kindness. And thanks for everything you do.
Thank you so much for joining us, Anna. That was a really amazing presentation, and I definitely learned a lot. And
Have a good day, everyone.
yeah, you too.
Bye.
Bye. Okay, so I think in about 5 minutes, a little less than 5 minutes, there is a bargaining caucus that's gonna start on a different Zoom. And does anyone have, okay, here it is. So here's the bargaining RSVP link in the chat. If you haven't filled it out already, you can get the link to the caucus and then later the bargaining session there. If you go from here to the caucus and then bargaining, please hold on to the sign in, sign out link so you can sign out whenever you do leave. Yeah, and if you have any questions about transitioning there, or if you would like to stick around here and do some more admin blasting, that's totally fine too. But let me know. Or another Picket captain. Sorry, Serena.
No, thank you so much, Louisa. I wonder if there is a separate link for the caucus.
Nope. Those are, you'll get both links. Well, there are two links, but you get both of those links at the RSVP.
Okay, all right. And I think that going to bargaining meeting also counts towards strike hours, right?
Yep.
Yeah. And yeah, I think the caucus is sort of really important because the bargaining committee will introduce everyone to the new package that they're suggesting, right?
Yeah, that's what they have said.
Right. So just for those who didn't know.
Okay. Yeah, it takes a couple minutes to get the bargaining links from the RSVP because we send them manually. But it shouldn't be more than a couple minutes. And if you're going straight to the caucus from here, you don't have to sign out and sign in again. You can just sign out when you leave.
Oh, and I see the links for caucus and bargaining also in the chat by posted by Nadim.
Okay.
So
it is really important that you read through the bargaining guidelines, which I can post in the chat too. Yeah, please make sure to do that. Also, just one thing, if you get the direct Zoom link from someone else, if you can try and make sure to register as yourself, it's a lot harder for people who are signing in if there's multiple people with the same name, because then we can't tell if you're signing in or what's going on. And it's 1 o'clock, so I think the caucus is beginning now. I think it's really up to you on the caucus or bargaining. They happen at different times because that's how bargaining works. So you can attend both. To be clear, the caucus is what is happening right now.